It's
Is it?
Calderon, Kevin.
Oh, I'm sorry, Dr. Calderon.
That's fine.
Sorry. Okay. All right. Go ahead, doctor.
Yeah, hi. I hope everyone can hear me. My name is Shadi. I am currently, just a little bit about myself. I'm currently a PGY4 general surgery resident at Staten Island University Hospital General Surgery Residency Program in New York. A little bit about myself. I went to medical school in Touro University College of Osteopathic Medicine in Nevada. I did my master's in physiology and biophysics at Georgetown. And here I am doing residency with an interest in trauma and acute care surgery. So I'm applying to fellowships actively, and I'm really looking forward to this session and the opportunity just to go over this really interesting case, and just kind of hearing from you all and your expertise and having actual experiences probably akin to this case. And so I hope that it instigates really great, meaningful discussion and interesting topics. So I'm really looking forward to it. There are some opportunities for breaks in my chat. But please, Dr. Calderon, thank you for moderating, and I hope that we have a lot to talk about. So without further ado, I guess I'll continue. So my presentation, from seatbelt sign to second look, navigating bucket handle injuries. And I find this type of injury interesting in just the literature review I've done. There's not a whole lot of body of evidence on just reported things. There's a couple case presentations and just retrospective analyses of bucket handle injuries that have been observed, but there's not a lot on management. So there's still a lot out there to be standardized or maybe protocolized about the management of bucket handle injuries. So just to continue, I have no disclosures related to this presentation. So the case. So this was a 46-year-old female, no significant past medical history. She presented to the ED after a motor vehicle accident. She was a restrained passenger in a motor vehicle accident. She was in the what is it, passenger seat on. Her husband was driving. The car was hit on the driver's side. The car spun out, hit a tree, and then the car actually set aflame. Like it went on fire. The husband self-extricated himself and then got her out of the car, and were assisted with emergency medical services and brought to the trauma bay. So initial presentation, the patient, primary survey, the airway was intact. Breathing was equal bilateral air entry. Circulation, the patient was tachycardic initially on presentation to the 1 teens. Blood pressure 110/60. The shock index on arrival was about 1.1. No visible deformities. However, the patient did have a visible seatbelt sign on physical exam with tenderness diffusely in the abdomen, not specifically peritoneal, but definitely had tenderness to palpation. And a FAST was performed as well, which was positive. I'll go over that image as well. And then just further going on to the secondary survey, like I mentioned, there was diffuse abdominal pain. The patient's heart rate did improve with a crystalloid bolus and 1 unit packed red blood cell when they arrived. And just given the seatbelt sign, the tachycardia, and just the mechanism of injury, the patient initially presented as an alert and was upgraded to code trauma status when they arrived as well. So the FAST, just to go over, and I kind of captured this image, was positive, very, very positive for the right upper quadrant, the left upper quadrant, and in the pelvis as well. So I just wanted to provide that image because I find it to be interesting. And so as you can see, this is the right upper quadrant. Apologize for the static delay. This was the bladder. And so there's some here. You can see some of this extra fluid. Left upper quadrant with diffusely positive, with lots of spacing there. And so that was the FAST. And so a pause or a break is what to do next. You know, there are, Dr. Calderon, if you wanted to intercept, I can, yeah, absolutely.
Yes, thank you, Arjmand. Thank you for this case. So we have in a female patient, tachycardic at the beginning that responded to crystalloids and abdominal signs, fast positive. So can we ask Dr. Untrak, please tell us what to do in this case, or what would you do?
Yeah, certainly. Now you say the patient the pulse responded. How did it respond?
It did respond. The patient was, after this crystalloid and also a 1 unit packed red blood cell, they were no longer tachycardic and they remained normotensive.
Okay, so no longer tachycardic. Well, in this case, based on the title or the objectives that you wrote, you went to CAT scan, but I assume that the EFAS, the extended portion, was negative. So there was no chest injury. And with that, assuming that was negative, I would have, I personally, I would have gone to the operating room. It's pretty straightforward. But it seems like you went to CAT scan. I wouldn't take her to the ICU if she clearly positive fast.
I'd have to call the wrong. Yes.
Yes, thank you, Dr. Rundrecht. So can we ask, please, Dr. Frisby?
Well, I agree. I think most probably if you go to a CAT scan, don't leave her there. Stay right with her. There's a reason that's called the death room. If you think everything's fine and she's got plenty of reserve, but this is a lady, this is a woman. She's not as hardy as a man is, and she can run out of gas really, really quickly on you. So if you're going to go to the CAT scan, which is appropriate here, I think, although Stephen's right, if you got positive ultrasound, just open her. But that's all my comment is.
Yes, thank you, Dr. Frisby. So we have between the attendees, we have Dr. Stephen Epstein. Dr. Epstein, would you like to make a comment?
Yes.
Hello.
Thank you. It's always a very close call. That's the whole thing. But if I recall from the literature, if you wait and you see abdominal signs and you go within 12 hours, then the rate of complications is no different. So what will you have? You're thinking bucket handle, you're thinking rupture, and you can wait. Personally, I think most of these folks develop peritoneal signs, so you can watch for a while. I'd like to ask you why you gave a unit of blood.
Well, I will say I wasn't there presently, like myself in this case, but I believe it was because of the diffusely positive fast and the tachycardia. I think that there was a concern that the risk and the likelihood of bleeding was imminent, so that they gave a unit of blood after initially resuscitating with a 1 crystalloid liter. So I think that was the part of the decision-making process.
And Dr. Untrack had asked, was the patient responsive to 1 liter of crystalloid?
So from the documentation, the record, it did appear that they were responsive to, and it was kind of stated as such, both after the crystalloid and the 1 unit was given, the patient was no longer tachycardic. So it's kind of unclear whether it was like immediately after just the bolus or it was after both, but after they got both of them, documented that the patient was no longer tachycardic. So not entirely clear.
So I would have waited a little bit and watch the patient. They become tender very quickly, whether it's a rupture or a bucket handle, and you can still operate without any change in outcome, probably up to 12 hours.
Yes, thank you, Dr. Epstein. We have Dr. Kasim. Would you like to make a comment?
Couple of observation. Before you do the CAT scan, wouldn't it be prudent to do a KUB if there is a lot of fluid and if there is air under the diaphragm? Then you're done. That's one observation that I would have done. Second, did you do any blood work before you gave the patient 1 unit of blood?
I know that typically in our trauma bay, like they're obtained, but I would be surprised if anything was resulted by that time. I'm sure that it was unlikely resulted. Yeah. So it's certainly given.
By and large, I don't like the idea of giving 1 unit of blood, and I'm sure you agree with me as well. But sometimes we get a little excited and we see something like this and said, oh my God, he may be bleeding with all the fluid in the abdomen. Let's give him, let's get ahead of the game by giving him a unit of blood. Not a good idea, but we do it anyhow. Yeah, a lot of people do it. Even I'm sure that I have done it in my career. I think In this particular case, I'm not sure whether CAT scan is going to add more than what I have already seen in the trauma bay of this particular patient. He is hypotensive to begin with, or tachycardic, and you resuscitated him, and he's got belly full of fluids, and the fluid must have come from somewhere. So I think CAT scan is not going to add all that much unless you want to document something. But I think the comment from Dr. Epstein is a very good one. More often than not, we do a CAT scan and it is negative, and then we put the patient in the ward and watch him for a little longer. I think you would have just leave the patient and watch him for a little longer and then embark on a CAT scan may be a better idea. That's my observation and in my experience. Thank you.
Thank you, Dr. Kasim. Dr. Arjmand, would you like to make a comment, please?
Yes, sure. I would do the things a little bit different. First, this patient came in some state of shock, and she responded to the fluids. The current recommendation from the American College of Surgeons is to give 1 liter of crystalloid, and if the patient is still hemodynamically unstable, to go straight to PRBCs. So I cannot fault anyone by doing this on this particular patient. You obviously know that the patient has a significant intra-abdominal injury because you see fluid in the initial ultrasound. Ultrasound is not very sensitive for very small amounts of fluids. In order to see the fluid, you have to have at least 500 mL of fluid, either blood or intestinal or gastric contents free in the abdomen so early. And this has been studies on this, that they kind of like follow the amount of fluid that needs to be visible on the ultrasound. So you have a patient who has a significant amount of fluid, probably most likely than not, we need to go to the OR. So let me place devil's advocate here. What happened is this was a splenic injury that stopped bleeding by now. We don't know. What happened, it was a liver injury, even more likely to have stopped bleeding, and it's not bleeding now. So as Dr. Epstein said, you can wait, I don't know if 12 hours, but you can wait for peritonitis to develop. And I can tell you from personal experience that patients who have a bowel injury, in 2 hours, they are begging you to take them to the operating room. If they are awake, they will have significant pain. So if that will be the concern, it's okay to wait. But in this patient, probably you have to go to the operating room no matter what. So why would I do a CAT scan before? This was a high-speed injury. I don't know if the patient has another injury and recognize. Now we know because it's obviously that he will have a buccal injury, but we don't know what type of injury the patient has. What happens if he has also, for example, an aortic tear that goes unrecognized? And so I think if the patient is hemodynamically stable after receiving the unit of PRBCs, accompanying the patient to the scanner and do a scan, I think it's a good practice. Granted that he is to be ready to change plans immediately and rush that patient to the OR if the patient becomes unstable. But in this patient, you have time. The CAT scan can offer additional information that we don't know and see what happens. And Dr. Kasim mentioned the KUB. We routinely do a pelvic and a chest X-ray, which is very sensitive for free air. If you have free air, yes, you know that you need to go to the operating room no matter what. However, I still argue that maybe you have time to do a CAT scan. If the patient is unstable, just go to the OR and start the scene. So that would be my slightly different approach. Thank you.
Thank you, Dr. Arjmand. Thank you all for all the comments. So Dr. Arjmand, please keep going. What did you do with the patient?
Yes. So continued. So this patient, as was mentioned previously, like the patient was taken to the CAT scan. They had a CT angio, chest, and pelvis that was performed, and it did demonstrate, as we expected, diffuse hemoperitoneum with pneumoperitoneum. The radiologist had interpreted it, and we looked at it. There was concern for small bowel injury as well as SMA injury. They believe that there might be an area of active extravasation. I'll show the image as well. There were also identified some rib fractures left 7 through 10. And so subsequently, after the patient left the scanner, the decision was to go to the OR for exploration. And at the same time, vascular surgery was notified for this concern for SMA injury, just kind of to start with. And here's the image. I hope I can scroll through it so we can see kind of nicely. Okay. Kind of fast, but so that area that we just passed by, I can try to go through again. Let me see, was what they were calling, and I'm going to scroll through it. This little blush here is what they were concerned for SMA injury. And then obviously you can see like the diffuse hemoperitoneum as well, all of the extending into the pelvis as well. I can go through it one more time if anyone wants, but this is what we were looking at. So moving on to the operative details. So yes, we proceeded to perform an exploratory laparotomy. Oh, and just to go kind of circle back on the commentary before, I kind of agree. I just do think that with the advent of CT scanning just being so much more efficient and so much more easily obtainable between the trauma bay and the OR has really changed, like, you know, how much we're able to accomplish in that, even within an hour's time, before a patient does become peritoneal. So I think that that's like greatly advantageous and something that we think about often because, you know, we're able to get patients through a scanner and so much more efficiently probably than was in the past. And so, and that's a great thing too. Whether that is able to allow for more information to be gathered from a scan with full of blood in the belly, who, you know, that's to tell. But yeah, so this is the operative details. On entry, you know, there was 1 liter of hemoperitoneum that was encountered. All 4 quadrants were packed. So the left lower quadrant was clear. There were no obvious injuries. The right lower quadrant did demonstrate a cecal serosal tear, and it was not full thickness. It was repaired primarily with Vicol suturing. There was a mesenteric hematoma in this aspect that was noted, however, non-expanding. This was also at the point at which vascular surgery was in the room, and they did put a Doppler to it. They did take their own look as well. They were not concerned or for any like large arterial injury, and there was Doppler signal present, so their recommendation was not to intervene or explore in this hematoma further. They're not concerned for SMA injury. Additionally, a grade 2 splenic laceration was identified. And then these bucket handle injuries, as we have already mentioned, 2 in the proximal ilium, and then 1, as I mentioned here, in the jejunum associated with a small bowel perforation. These areas of the affected ilium and jejunum were subsequently resected. One of the mesenteric defects was primarily repaired with Vicryl, because the bowel in that segment was viable, and then quick clot was placed in the left upper quadrant on and around that splenic laceration, which achieved hemostasis. So this is the initial surgery. There were no anastomosis made, just secondary to concern for bowel viability. And these are some gross images from the surgery. So these are some of the segments that you can see, just that mesenteric hematoma. And then these are the bucket handle injuries. Oh, my second image didn't really load properly, but this is one of them. And this is an example of what was an area that was resected. So another pause in my presentation was what to do next when you're intraoperative and you're observing these injuries and the extent of injuries that I'd mentioned. Dr. Calderon, if you wanted to moderate now.
Some question. What is that? How far is your trauma bay to the CT scan and to the CT scan to the operating room?
I'd say, I mean, less than 200 feet away. Yeah, it's really just down a single ramp that gets you into the scanners that we use during our code trauma. So it's very accessible. Yep.
Okay, so let's ask Dr. Frisbee. Dr. Frisbee, please, what do you think about the CT scan? Was it helpful? And what do you think about the case? What would you do next? Dr. Arjmand is asking.
Well, CT scan's always helpful if you find something, that you didn't expect, which is why you do it. So in this case, you knew what you were going to get because you had all these obvious signs. Thank goodness it didn't have, with all those fractured ribs on the left, I was suspecting that it really had a real laceration of the spleen, but only a number 2. So it's okay. But the question now comes up, what do we do with these pieces? Do we do we put them back together, or do we exteriorize them, or what do we do? It's all small bowel, I understand. There's no large bowel involved.
Yeah, aside from that, serosal injury on the cecum, no large bowel was involved.
Okay. Tell me about the spillage. How much of it was all over the place?
From what I understand, there was not a lot of contamination, if at all, of any enteric spillage, just really blood, just the hemoperitoneum. So not a lot of gross contamination from enteric content, from what I understand.
Okay, in that case, I would wash them out and put the pieces back together. Can you get it back together without any tension and a good blood supply? If you can, just go ahead and do it.
Okay.
That's all I've got.
Thank you so much, Dr. Frisbee. Dr. Arjmand, one question maybe the analysts may ask. How are the hemodynamics of the patient during the operating room, and how does the ABG look like?
From what I understand, that patient was starting to become coagulopathic towards the end of the procedure. I don't have the ABG, unfortunately, on me, but I don't believe that they were reported to be acidotic at all during the case. So that's from what I understand, yeah.
Yeah, thank you. So let's ask Dr. Epstein. Dr. Epstein, what would you do next with the patient?
I think I'd do pretty much the same. I'd like to know the distance between pieces. If it's very short, I might remove one piece of intestine, try to limit the number of anastomoses if you're going to do several resections. And that's in front of the surgeon that's operating. The idea of quick clot is very good. Back in the time, we wouldn't operate on just an isolated grade 2 spleen. But if you're going to operate, I don't know, I don't have a personal experience with quick clot in the spleen, but back in the day, and I'm a little older, we would wrap, if we operated on a grade 2, we would wrap it in Vicryl. I'm sure that nobody thought of that at the time, and probably nobody's done it. But otherwise, and the question is also, do you put a suture in the serosal tear? Do you know what the literature suggests?
I'm not entirely sure. But I think that's what my experience, just like anecdotally, like we do put like a Vicryl stitch, but I'm not sure what the body of literature suggests. No.
So if I recall, the idea was there was literature, and it may have changed, not to put a suture in a serosal tear.
Was that true for both colon and small intestine? I'm just curious.
From what I remember, the answer is yes.
Thank
And
you.
the other thing is, of course, you sewed your intestine. You could use a stapler. You want to get out. You said that the patient was starting to get coagulopathic. And you want to use the stapler before you wind up with too much edema in the bowel from anesthesia giving too much crystalloid.
Yeah. Yeah.
That's it for me.
Yes, thank you, Dr. Epstein. Can we ask Dr. Kassim, please? Can we have your comment?
Well, there are several factors that you need to consider in this particular case. First of all, when you do a CT, you're looking for what is called dirty peritoneum sign. If it is present, It's not always present. If it is present, that's a telltale sign for bucket handle injury. And I don't know whether you saw it in this particular case or not, but it's something that you need to think about. Second thing, the hole in the small bowel, is it a small little laceration, or is it a more than 50% laceration? And that determines whether you do a primary repair or not, or you do a resection. And the third thing is, you always suture the serosa, in my opinion. I think if you leave, it's for aesthetic reason. You just bring the serosa back together and cover it up. And sometimes you also put a piece of momentum on top of it. And the third thing is, it also the three things that you need to look for, whether you're going to do an anastomosis, especially in large bowel, it may be also applicable in small bowel. Time of surgery, the amount of blood that you have used, and the presence of acidosis. And all these factors play in to do whether you're going to do an anastomosis or not. But by and large, in small bowel injury, and these are not that important as it is in the colonic injury. And I think I would just go ahead and resect what doesn't look healthy, and then put it back together in 2 layers. I prefer hand anastomosis to staple anastomosis because I'm old-fashioned like Dr. Epstein, and that's how I grew up, and that's what I like to follow. And the third thing is coagulopathy in a patient of this nature. That means that he must have been, taken time to extricate from the injury, and time in the trauma bay, and time in the operating room, all those. In other words, much time has been passed to make him coagulopathic, as well as giving him lots of fluid, blood or saline. I think you want to avoid all that. So in summary, I think I would have done exactly what you did. Close the defect, resect the bowel if it doesn't look good, patch the serosa, and get out, wash the abdomen. Oh, third thing, so about the spleen. I'm of the same idea as Dr. Epstein. I'm old school. I have done many vacuum wrap to the spleen, and I never had any problem with that as well. And I would still do it if I have a splenic injury, 2 centimeter laceration. Thank you.
Thank you, Dr. Kasim, for the wise comments. It's always a pleasure listening to you. So can we hear now, Dr. Arjmand, please, can you make a comment about the case?
Yes, first I need to apologize because normally when I am at this, I take notes about what I'm going to say before I speak. And I don't know if anybody noticed, but English is my second language. So now sitting in the car, my comments will be worse than ever. A few things regarding many things. First, the buccal injury. I would like to clarify something. If this patient can have a bowel injury or can have a buccal injury. A bowel injury, you can wait until it declares itself and go in 2 hours and operate usually without any other problems. A buccal injury, when you have the vascularization of the bowel with open vessels in the mesentery, which is what you see in the CAT scan, you need to go immediately because that patient will continue to bleed. So those are 2 different categories. So you can have bowel injury without mesenteric injury. You can wait and go in 2 hours, or you can have what you have in this case, and you need to go very soon. So that's one thing. When I am there, I am a firm believer in the KISS principle. Keep it simple is stupid. Maybe you could argue because I am stupid. But I will do the minimum necessary to get out. This patient is already coagulopathic. Have a big metabolic demands already. So I wouldn't do the perfect operation. I would be a good enough operation and get out of the operating room. So I will staple the bowel, not an anastomosis, just staple the bowel close, control the bleeding and the mesentery, and get out. Regarding the spleen and the colon, I always close the serosal tears, but I agree with Dr. Epstein, it's probably not necessary. And I have cases where the patient is really, really sick, and I have not closed the serosal tears in the bowel and in the colon, and nothing ever happened that I remember. But I also agree with Dr. Kasim, looks better when you repair. So if I have the time, I will repair. And regarding the spleen, if it's not bleeding, I would not do anything. It's part of the KISS principle. In order to do any repair of the spleen, either a suture, which is what I do nowadays, I don't do the wraps anymore. The wraps usually ended up having a necrosis of the spleen, at least for me. You need to mobilize the spleen. You cannot repair the spleen in situ. So you need to mobilize the spleen. You risk making the situation worse. And this adds a lot of time to a patient who is hemodynamically unstable. So if I have a patient who is coagulopathy and I have any concern, I would probably remove the spleen. If it's not, I will just pack and get out and wait to fight another day. That's all I have for this case at this time. Thank you.
Yeah. Thank you, Dr. Arjmand. And finally, Dr. Untracht, please, can you please make your comment? And I think you also have a question for Dr. Epstein. Is it right?
Yeah, yes, you're right, as I put in the chat. Well, about the bowel anastomosis for a patient that was not in shock, remained stable in the operating room and got only 1 unit of packed cells, it's perfectly okay to do an anastomosis. So I think now the coagulopathy complicates things. Was the patient really coagulopathic? Do you have a TEG, a ROTEM analysis? And I think that raises the issue. A very good point is when the patient comes in, not to forget tranexamic acid, especially with a positive fast. Just go ahead and do that, and then maybe the patient wouldn't have developed a coagulopathy. But if it's a coagulopathy in the setting of circulatory shock, then you shouldn't do an anastomosis. I think it's perfectly fine to staple the ends closed and leave the apthera. But you know, barring the coagulopathy, in this case, I would have done an anastomosis. I like to hand sew everything. That's the way I was trained. But in this case, in trauma, I would usually go ahead and staple it, use a GI stapler for that to keep the operation short. And about the CAT scan, in the old days, I would operate for this. In the old days, our FAST back in the 80s was a diagnostic peritoneal lavage, which you've probably never seen, probably never did, but that would show gross blood. We would just operate. But for the reasons that Dr. Hochman mentioned, a patient like this should have a CT scan, if not before, then after, when everything is stable, simply to rule out an aortic rupture, which could have happened in this case, rule out a occult spinal fracture, rule out the occult injuries that you wouldn't know about and you don't want to be surprised about. So that's a very good point. In this case, it's perfectly based on the patient's status. It was perfectly okay to go to the operating room first. If not, I would have gone after, and then you see that thing in the SMA, and then the belly's already closed, and you worry, but I wouldn't have been too concerned about doing the CT scan first. And for Dr. Epstein, what's the rationale for not suturing the serosa? If it causes harm, I can understand that, but for something that doesn't cause any harm, that takes 30 seconds, to put a stitch or two, or a minute, whatever, I would tend to sew it closed, to just put 1 or 2 serosal sutures. But what's the rationale for not putting the sutures in?
Apparently, there was an increase in adhesions, and while we were talking, I just went through ChatGPT, which is I'm just learning about this. And so superficial serosal tear, most surgeons do not close it. It will usually heal on its own. Suturing may cause unnecessary ischemia or narrowing. There was literature way back, I didn't use ChatGPT back then, and there was literature that said you did not need to close the serosal tear. Dr. Kasim closes it because it looks good. That's all right.
Well, the first rule, first do no harm. So, and they say, well, you cause more laceration, more adhesions. And so that suggests that if they did a randomized prospective double-blinded study, and they had found out that patients went back to the OR years later for small bowel obstruction due to those adhesions. Okay, but I would be surprised if that study were actually done.
I think we would have to go back in the literature quite a few years.
Yeah, and probably that kind of a study was not done. But anyway, point well taken.
Well, thank you, Dr. Umbreg and Dr. Epstein. So can we continue with the case, please, Dr. Arjmand?
Yes, of course. And just for completion's sake, there were the areas that were injured. So there were 3 areas of small bowel with a traumatic small bowel perforation, 2 in the ileum and 1 in the jejunum, associated, all of them with bucket handle injuries. And almost it appeared, from the pictures at least and from discussion with the surgeons involved, that the bowel was almost, in some parts, remained very viable appearing, but just totally devascularized in the mesentery. And so what ended up happening, that there were segments, 23 centimeters and 17 segments of ileum resected each, and then 8 centimeters of jejunum resected each. This was all done with a GIA stapler. There were no anastomosis made, like I mentioned, due to that's a concern for the patient becoming coagulopathic. And so the patient and the abdomen was left open. So the next part is, returning to the OR. So the patient was re-explored. 3 small bowel anastomoses were created. There weren't any further areas of small bowel that appeared non-viable. There were no other non-viable areas of colon either that were observed. That cecal repair appeared to be intact. The mesenteric hematoma that they observed was stable. Spleen was hemostatic. So the abdomen was closed. The patient was, all the anastomoses were made, extubated overnight. And that patient did remarkably well. Their entire hospital stay was only about 12 days, which is actually averages around 14 for these types of injuries. So it's patient did remarkably well. And so that was the patient's hospital course. My next slide is probably maybe difficult to see, but now I'm just reviewing kind of literature and management that's out there on the management of this blunt abdominal injury and just what the ATLS algorithms do suggest, So then the first question being is the patient stable, considering the mechanism of injury, yes or no? And in this case, this patient was what we call a transient responder. They were tachycardic but normotensive and saturating well and airway protected, and they're transient responsive to the fluid. So if we consider that to be someone who is stable, then we would put them in the scanner. However, if you're talking about when the patient first arrived, a FAST that was positive would, buy you into the laparotomy straight. So that is part of the typical protocol. And that's what the algorithm is as presently. And so moving on to just a review of just bucket handle mesenteric injury and just review that I was looking into and about the nature of these injuries, the pathology. So when blunt abdominal trauma has injuries to the bowel, it usually falls under 3 categories: crush injuries between himself and an object, in the rigid skeleton. So the seatbelt and against the skeleton of the patient; deceleration injuries, shearing forces created between fixed and mobile segments of bowel. And then burst injuries, closed off during blunt force to the abdomen. And then the bucket handle injury, as we're talking about, is an example of a devascularization or thought to be a deceleration injury, often due to the high speed associated with lap seatbelts, compressive forces like bicycle handlebar injuries, or just direct blunt force to the abdomen. And so the areas between the fixed and mobile segments, such as the ligament of Treitz, are particularly vulnerable to these tears, majority between that proximal jejunum and then also the distal ileum near the ileocecal valve, or where, and it kind of tracks for this patient's case as well. So that was just interesting to look into. And so just further manage it. So diagnosis often of bucket handle injuries is delayed, and that increases the risk of ischemic bowel sepsis, perforation, and death. Once diagnosed, more often than not, bowel resection and anastomosis is usually required. And then because these initial devascularizing injuries and the redundancy of the collateralization of the flow, these anastomoses are typically often thought to be at higher risk of failure to heal. I was looking at just some studies and what's out there on some retrospective kind of reviews of what of bucket handle injuries. One of them I was looking into was just talking about the risk of leaks comparing colon and small bowel, and actually two different very large papers suggested the same thing, that small bowel anastomotic leaks are actually a lot less frequent, in that colonic leaks are more likely with colonic bucket handle injuries compared to small bowel. So I found that to be interesting. And then let's see, and then and then another, like I mentioned, this multi-center retrospective cohort just reviewed about like 900 records. 610 of them were small bowel injuries, 391 colonic. Of these small bowel injuries, like I said, 63% were small bowel, and then 53 colonic. An AL, just being anastomotic leak, occurred in about 5% of bucket handle injuries, and where non-bucket handle small bowel injuries, 1%. So anastomotic leaks were associated with a higher percentage likelihood. Anastomotic leaks were diagnosed about 11 days from index operation in the small intestine bucket handle injuries, and then in 9 plus or minus 4 on colonic bucket handle injuries. So a lot of these presentations were often delayed in diagnosis. Anastomotic leak does increase the risk of infections. They found ventilator days, ICU with total length of stay, reoperation, readmission, although mortality was overall unchanged. And some of the conclusions that came out of this multi-center retrospective study was that bucket handle carries a significantly higher risk of leak, particularly in the colon, than other blunt intestinal injuries. Bucket handle had a high risk of leak, colonic being higher than small bowel. The anastomotic leak usually detected in the second week and after anastomosis. Delay was associated with an increase. Delay was in diagnosis was not associated with an increased anastomotic leak, almost kind of to support the idea of sometimes allowing things to declare themselves. And then primary anastomosis also did not increase the anastomotic leak rate. So that as opposed to ostomy and creation. So that's another like kind of interesting topic too, especially and then this is something else that these papers was touching on, was the fact that because the colonic bucket handle injuries do have a higher leak rate that's being reported on, should we have a higher consideration of ostomy in these patients instead of anastomosing them. So that was something that some of these papers, that of course, like there's not enough data, like primary data out there, but it was just something that was considered to be a suggestion. So Dr. Calderon, I know I just said a lot of things. If you wanted to intercept at all, these were just some of the major ways. Lastly,
yes, first of all, Dr. Yoshiro Kobe from Tokyo is asking, when did you resume the diet on the patient if she developed any postoperative ileus?
This patient did not.
And when did you resume the diet on the patient?
So this patient did come out of the operating room with being intubated and also with an NG tube left in place. They were extubated that night, and then I think it was maybe another 24 hours later, patient had the NG tube removed and started on a clear liquid diet.
Good. So this was a wonderful case and a good review. Congratulations. The reason I was asking a lot about the CT scan, was it useful or not, is because we have to answer the question, what if we don't have a CT scan available? What is it on malfunction? We have to decide between keep the patient under observation, transferring away to another hospital, or just explore the patient, take the patient over. And I will ask his comments about that. Let's start with Dr. Epstein. Dr. Epstein, please, do you have some final comments for that?
One, it's always fun to discuss these cases. The longest time that surgeons wait, and I'm sure that all the surgeons operating, is from when you make your anastomosis till the patient opens up and you have no leak. it's the public does not understand what we go through while you wait, because nobody wants a complication. And in these cases, it's terrible. I don't have anything else to add. Oh, the liver. By the way, when a liver has a crack in it, the liver enzymes will come back abnormal. Little secret, except, you can't wait till those enzymes come back. But a liver fracture will have elevated enzymes. But great case, and obviously it turned out great.
Yes.
So thank you.
Thank you, Dr. Armstein, and thank you for coming today. Dr. Kassim, please, your final comments.
Well, the takeaway message is quite often when you see blunt abdominal trauma, whether it is MVA or bicycle handle injury, quite often the patient will present with benign finding, and it behooves the surgeon to use his ingenuity to distinguish which patient is sick and which patient is not. But in my experience, what I have seen is quite often the patient is sent home and the patient comes back 3-4 days later with peritonitis. And therein lies the critical message of bucket handle injuries, blunt abdominal injury with seatbelt sign or handlebar sign. And don't ignore them, and be cognizant of the fact the patient may have something serious, and don't let them go home too quick. Thank you.
Thank you, Dr. Kassim. We have Dr. Arjmand, please, your final comments.
I would like to start by congratulating Shadi in this presentation. No, I'm very serious. Your presentation was really excellent. You have composure, you research the topic very well, you answer the questions at a level way beyond a PGY4. Your program director should be very proud of you, and I hope you continue in that trajectory, because it really was, and we hear a lot of presentations every week, and this is kind of like almost like the gold standard. Very good. That's the first thing I want to get out of my chest. Secondly, I probably have handled the case exactly like you did, with minor variations. One question maybe for another meeting is, we don't use Aptera. We use a simple method for closing that is much cheaper. And we can discuss the cost of doing things that way. And one final comment about injuries from seatbelt. Seatbelts, when I see a mark from the seatbelt, either in the abdomen, the chest, or the neck, I am very worried about those. If I see in the abdomen, it's usually because the seatbelt was put too high, not in the position it should be. And as Dr. Kassim mentioned, the chances of a bowel injury increases with that. It's also a chance of having an abdominal wall injury with disruption of the abdominal wall muscles at the level of the seatbelt. In the chest, what will happen is external fractures. External fractures are the most common cause nowadays, is the seatbelt fracture in the sternum by flexion. It's important that 15% of those patients will have an associated spinal fracture, compression fracture. So when we have external fracture resulting from the seatbelt, this is something that we need to look. And finally, the seatbelt is riding too high in the neck, and we see a tattoo in the neck, we always do a CTA, because a significant number of those patients will have either an intimal tear or even a dissection. But that's all I have to add to this interesting case. Thank you.
Thank you, Dr. Arjmand. Many teaching points, very sweet words to Dr. Arjmand, who had an excellent presentation. Please enjoy your travels in Miami. Do we have Dr. Untrak, please, your final comments?
Yeah, so I would second Dr. Hockman's comments about the presentation. Very well done, and you have a bright future. I was a little confused by that last conclusion on your last slide of the literature review, that primary anastomosis does not increase the leak rate, which I guess if you take everything together, it means that whether you do it at the first operation or delay, there's no point in delaying because the leak rate is going to be the same. So I think that's what they're saying. Maybe you can clarify, but otherwise it seems contradictory. And, if this patient were not coagulopathic, then would have gone ahead and, you know, if everything else looked good, done the earlier anastomosis. But maybe you can comment on that last conclusion, how you reconcile all that. But otherwise, very well done, and it was an excellent case for discussion because it raised a couple of points in management that were well reinforced.
Yes. Thank you, Dr. Untrack. Finally, we have Dr. Frisbee. Can you make your final comments, please?
Sure. The case is well presented, as Dr. Arjmand said, and I believe what my friend Kasim said. You know, I was trained in New York City back when dirt was young, and frankly, we were taught to do, especially for the colon, not so much for the small intestine, but for the colonic injuries, 2 layers. You always do a 2-layer closure. They were really proud of that Connell stitch. And as a result, I have a real bias toward that. And frankly, I see how it could be that there is a higher leak rate in the colon when you use the stapler than if you did it by hand. But I can also see that the time saved may be what you need. In this case, stapling is fine, but you did a great job and very nice presentation. You will do well.
Thank
Yes,
you.
thank you, Dr. Kasim. Thank you, everybody. So good presentation. An excellent presentation and review. So we say thank you, and thank you, everybody, for the comments. I hope you have all a good day. Kevin Miller, anything else to say?
No, Dr. Calderon, thank you for moderating, and Dr. Arjmand, thank you for the presentation. That's it. Everyone have a very nice day.
Hey, Kevin, can I just,
Yes.
you said that
Yes.
you inquired as to whether they'll be lenient and grant.
And they never responded to me.
Okay. Well, if
If they do, I will let you all know.
great.
Yeah, if they do, they can add the CMA through their system.
Oh,
So you'll find out if they get back to me or not. I was hoping they
Kevin,
would by the
let
end of
me
the
ask you
meeting.
this. What
Yeah.
about today's?
No, that's the one I'm referring to.
Oh, really?
Yeah.
Oh, good.
So,
All right.
a quick question for the people at University of Miami. I don't know if it's anybody still in the call. I know that when you do the temporary abdominal closure and you're trying to bring the fascia together, you have a method there with chest tubes and everything. But I would like to be able to discuss that with someone from there. Is anyone in the call right now that does that? No, I guess not. Okay.
Oh, wait a minute.
Okay.
We do a really inexpensive, closure, but it's done because it doesn't cost very much. If you're going to do a wound vac or whatever you want to call them, you can use a big sponge or a big 4x4, or not a 4x4, but a lap sponge, and put it in there. Put your chest tubes, after you cut several more holes, put them on top of that wet sponge. And,
no, Dr. Felipe, no, what I'm asking is something different.
Oh, I'm sorry.
Yeah, we use like a plastic, like a cassette for the X-ray. We put that on top and 2 drains and IOVAN, and we seal like that. But when we need to leave the abdomen open for several days, we keep going back every other day. We kind of decided now that we are going to stop using the Whitman patch, which is 2 gigantic pieces of Velcro, because that thing costs $8,000. And the thing that we used to tuck it in, which is some pieces of plastic with some, that cost, so essentially the whole thing costs $13,000. It's ridiculous. It's a ripoff. We have another device that we brought from Canada that costs $6,000, but I know that at Miami, at Riders, they use a system with 2 chest tubes and some Kelly clamps to bring the fascia together, because I saw that during one of the presentations. So we would like to switch to something like that probably costs $20 from $13,000. So, but I need somebody to, I remember taking pictures at that time during the presentation. So, oh, this is great, we should do the same thing, but we never did. And we never pay attention to the price until recently we find out that the thing that we're doing costs $13,000, which is ridiculous. So, yeah, and the same thing like the Aptera. The Aptera is also very expensive, and we use a method like you do, Dr. Frisbee, that is cost like $20
Yeah.
with the Ioban.
Right.
Yeah. Okay. Okay. Well, thank you very much, everybody. Sorry to keep you here. Thank you.
No,
See
great
you
Nice to
next
hear
week.
discussion.
from you.
Have a good day, everybody. Bye-bye.
All
Thank
right.
you.
Bye-bye.
Bye.
Thank you.
Thank you all so much.
See you, Shadi.
Thank you.